Mrs. XYZ, 64 years old female who has completed till 10th standard, who is a housewife, hailing from Sulur, belongs to class 2 socioeconomic status according to modified BG Prasad classification. She got admitted on 12/8/2023 and got examined 1 week after that. Chief complaints, lump in the left breast for the past 7 months. History of presenting illness. Patient was apparently doing well 7 months ago when she noticed a lump in the left breast, which was insidious in onset, started as a swelling of 1 into 2 centimeter, gradually progressed and attained the present size of around 3 into 3 centimeter approximately. The swelling is not associated with pain, fever, or trauma. There is no history of any skin changes overlying the swelling. There is no history of nipple discharge or nipple retraction or any nipple destruction. There is no history of any other swelling in the same side axilla or opposite breast and axilla or anywhere else in the body. There is no history of loss of weight or loss of appetite. There is no history of any skin irradiation. There is no history of OCP usage or hormone replacement therapy. There is no history suggestive of metastasis. Also, there is no history of any complaints in the right breast. Past history, she is a known case of hypertensive since 5 years and is on regular medications for the same. There is no other comorbid illnesses in my patient. There is no history of tuberculosis, no history of any medical or surgical interventions for the present complaints. She has undergone hysterectomy 5 months ago for the complaints of postmenopausal bleeding with abdominal pain, diagnosed to have an endometrial hyperplasia. Sterilization was done at her 25 years of age. There is no history of any allergy. Personal history, she is on a mixed diet. Her bowel and bladder habits are regular. Her appetite is good. She has adequate sleep. She is a non-smoker, non-alcoholic, and there is no history suggestive of high-risk behavior. Menstrual history, my patient attained menarche at 13 years of age. She had regular periods since then for 3 to 4 days in a 30-day cycle. She was married at 21 years of age. First live childbirth at 22 years of age. She attained menopause at 52 years of age. Obstetric history, she is para 2, live 2. There are 2 children, a full-term normal vaginal delivery. Both children were breastfed for up to 8 months. There is no history of any abortion. Family history, here is a pedigree chart. There is no history of BRCA-related malignancies or deaths in first-degree relatives of her family. Treatment history, she is on regular medications for the hypertension. Summary of history, a 64 years old postmenopausal woman has come with a painless progressive lump in the left breast for past 7 months. It initially started as a small swelling, gradually progressed to the present size of 3 into 3 centimeter with no history suggestive of distant metastasis. She is a known case of hypertensive since 5 years. Hysterectomy was done 5 months ago due to postmenopausal bleeding.
Yeah, we'll stop here. No? We'll discuss history and then go back. Can we go like that?
Yes, sir.
Yeah, go to the first line. Now, one first thing I want to tell you is don't use this short form KCO, yes bar O, because some examiners recently for in an MS examiner they said USG, TURP. Post graduation, undergraduate okay, but try to expand and write how far.
They may be commonly used ones, but they're not the standard ones. Everyone may not know these full forms. Never use BP. I also recommend the same thing. BP, PR. PR can be pulse rate or even per rectal. Surgeons are very fond of per rectal examination. Okay, so don't use these short forms. Okay, never. Okay. At the end of what do you think, Leena, your case? What are you dealing with?
So at the end of history, keeping the age of the patient in mind, she's 64 years old, postmenopausal women, sir. And there is a history of a breast lump that is, especially in the breast lump that is present for a 7 months duration, sir. So it is gradually progressing and it is painless. So I would mostly think of malignancy, sir, in this patient. Also, she has got a hysterectomy done in the past. Maybe that may be due to BRCA related.
Your first history was good. Hysterectomy, right? Hysterectomy, but otherwise, there's a quote. They say any breast lump, unless proved otherwise, you have to take it as malignancy. And your thing is very strong of 64 years. One age, second is postmenopausal, and a painless lump. So if they ask you the exam, why do you say 64 and postmenopausal? I think probably it could be a malignancy.
Yes, sir.
Now go to the next slide. Lump in 7 months, okay. Because will you get any benign condition of this in this age group? What is the commonest benign condition?
64 years.
No, what is the
Fibroadenoma.
general fibroadenoma?
Fibroadenoma.
It occur in the 64-year-old. It usually occurs in younger.
Fibroadenosis, sir?
Fibroadenoma.
Okay.
Fibroadenosis because she is postmenopausal. It usually occurs at the time of involution and evolution and involution. Fibroadenosis. And will you get a lump in a fibroadenosis? Usually not. It will be a granular-like feeling. The lump will not be palpable. The patient has themselves to say there's a lump. So benign condition is ruled out because fibroadenoma occurs only in a fat breast and in a premenopausal uterus, also in younger individuals, not at 64. So just what if they ask you, how do you rule out? So commonest one is fibroadenoma.
What are the common things of like sir asking the question? Common things at this age, like what is Andy?
Yes, sir. It is aberrations of normal development and involution, sir.
Okay.
It includes
During involution period, what can be possible? Benign conditions.
What is Andy? What is Andy? Please repeat.
Aberrations of normal development and involution.
Yes.
What other things possible at this age? What other lumps? Benign lumps. Breast cysts?
Cyst.
Possible?
Yes, the cyst can occur.
Okay. What other differentials you have in mind?
So phyllodes.
No, not phylloids. Very close. Another DD for this thing is traumatic fat necrosis.
Yes, sir. Traumatic fat.
No? Any trivial trauma could have. What is traumatic fat necrosis?
So following a trauma due to hematoma formation, that can be
not hematoma formation. That is different. Fat
due to the
necrosis.
trauma.
You see,
Necrosis of the
different. Hematoma is different. It's given there only. Traumatic fat necrosis. How fat necrosis occurs?
because of the due to the trauma, calcification and necrosis of the fat. That may resemble closely a carcinoma, sir. So,
Yeah.
That is not an hematoma, but some sort of calcification occurs in the fat. Fat undergoes necrosis.
Saponification of fat. Saponification because of the release of the this capillary bleeding. Okay, this calcium causes saponification of the fat. Okay, that's why it's called. Okay, fat necrosis.
It mimics carcinoma because it is hard in consistency. That is the reason why they say it mimics carcinoma. Okay. Now go to the next slide, ma. When she noticed line gradually not associated with pain, fever, and trauma. Why did you bring all this triad in your history?
So pain I asked because to rule out pain. Usually carcinoma is painless. Fever in case of any breast abscess, that can be fever. And trauma, as I said, traumatic fat necrosis can be the close baby. So I asked.
Can you name some painful swellings of the breast?
Acute mastitis.
Breast abscess is one.
Breast abscess.
Yes. Malignancy, very late stages. To start with, it is painless. In late stages, and it infiltrates or gets infected, skin infiltration. Okay, it can become painful. Not in the early stage. So you think of mastitis, breast abscess, is common. Fever, as you said, you wrote in no history of tuberculosis. Tuberculosis of the breast also can occur.
Yes, sir.
But very rare. Even filaries of the breast has occurred, but very rare condition.
What is Monders disease?
So Monders disease is the superficial thrombophlebitis of the veins, sir. It is mostly commonly seen in the superficial epigastric vein, or lateral thoracic vein.
Very good, very good.
And it is mostly seen in the inframammary region.
So it's a painful condition, right? So you can include all those things. So which inflammatory condition is not painful and not causing a fever in the breast?
Pages.
What is another way to ask is what is inflammatory carcinoma?
Inflammatory breast carcinoma.
Inflammatory carcinoma. The name only suggests it's
Tumor.
inflammatory.
Inflammatory breast carcinoma.
Not inflammation actually. Okay, it's a very aggressive type of tumor which mimics like a breast abscess or so because of the induration or the edema what are present. It's causes massive this Podaraj appearance. Okay, and it's an aggressive type of tumor. It's more of a clinical. It's not inflammation. Clear? This can be confused with the breast abscess. But how can you distinguish between breast abscess and inflammatory carcinomatosa? By absence of fever.
Appearance.
Okay, mainly absence of fever. In abscess, you will have severe fever and all. But in inflammatory carcinomatosa, you will not have fever and pain. Okay, but maximum this edema will be there in inflammatory carcinomatosa. More than 2/3.
Yes,
Clear? Okay. What are the
Skin changes?
Skin
changes, you said. What are the skin changes usually look in the over the swelling?
Because of the if the tumor is involving the ligaments of Cooper, there can be dimpling, puckering, sir. And because of the involvement of tumor involving the lactiferous sac, there can be nipple retraction and other skin changes, like if there is any ulceration or any satellite nodules. I was asking for that, sir.
What are the features of skin involvement in case of carcinoma breast?
Three things. Skin involvement, only there are three, sir. Satellite nodules, ulceration, purity or injection.
Very good.
You written no history of nipple discharge.
Yes,
okay,
sir.
Nipple retraction. What is the history you ask when you write for nipple retraction? Recent onset of nipple retraction.
That's more important. Okay.
Why a recent onset?
Because nipple retraction can also be present congenitally, sir.
The patient is not able to say it's I do not know whether it is recent or not. How will you differentiate whether it is due to malignancy or congenital?
During examination, I'll try to manually put the nipple. So if it is coming, then it is congenital. If it is due to tumor involvement, it won't.
Where else you get nipple retraction? Any other
ductectasia will get slit-like nipple retraction. So circumferential retraction is in case of carcinoma.
Very good.
Yeah. So you know about the nipple discharge. Nipple
yes,
destruction.
Yes.
Very good.
Where do you get nipple discharge?
So
nipple destruction, where do you get? Say, Paget's disease of the nipple. Is it actually a Paget's disease of the nipple? It is a subareolar infiltrative duct carcinoma. Okay, which destroys. Subareolar carcinoma only destroys. It's not actually a disease of the nipple. No, nipple discharge, when you ask for nipple discharge, what will you ask for?
The nipple discharge, frank blood or altered blood is seen in case of duct papilla.
Type of discharge, yes, one. Number two, is it single duct or multiple duct discharge? Yes, which is physiological, which is pathological? Multiple is physiological, single duct discharge is pathological.
Yes, then spontaneous or non-spontaneous?
Single duct discharge, which you think is malignancy, more in favor
of? Single duct discharge seen in duct papilla, sir?
No, is it blood or serum? Malignancy, what do you get?
Blood, sir. Bloody discharge, frank blood or altered blood.
Okay, go to the next slide. No history of swelling in the same side axilla, opposite or neck or anywhere else in the body. What do you mean by neck means where, ma?
Sir, I actually wanted to ask like supraclavicular fullness, anything for patient understanding.
So neck is a big one. So you should not next you can say the opposite breast axilla or anywhere else in the body is okay. They remove that neck. This neck is from the supraclavicular up to the.
If it's supraclavicular, what is the end staging?
The end staging.
Ipsilateral supraclavicular lymph node is enlarged means.
It is N3C, sir.
Very good. Earlier, it was considered to be distant metastasis, but nowadays it's considered to be loco-regional. Okay. Yeah.
Yes.
Can.
Hmm.
Excellent.
No history of. Why did you ask for skin irradiation, ma?
So actually, I asked irradiation for the similar, if there is any similar illness previously, she got any radiation therapy like that.
If not, what else possibilities?
If any lymphoma or some other malignant condition also, she would have been doing.
That's also a very long time back. Okay. Maybe it takes 15-20 years, more than that.
20 years.
So what
Should
type of
have been.
irradiation is given for lymphomas? Earlier days, now no more. Mantle radiotherapy. Okay, you should know. Neck and chest region was irradiated, and this no history of weight loss and appetite. It's not so common. Although for UGC it's accepted, but it's not so common in breast and thyroid cancers. Okay, weight loss. It's a more in visceral cancer, like let's say
Yeah.
intestinal.
Colonic stomach.
Oh, yes. Okay, not so peculiar for breast and maybe in the later stage because of cancer cachexia, but not in the early stages. Okay.
Why OCP and HRT you asked, ma?
So OCP usage, the current days of OCP, they are not giving the estrogen pills. So they are giving either progesterone only pills or combined pills. So it is not carrying
protective. Is it protective or harmful?
Actually,
there are two schools of thoughts. You can say it is protective. They say combined with progesterone, it is protective. They say, but some school they don't accept. But you have met. So no history of metastasis. Where you asked for hemoptysis. Why did you bring in hemoptysis? Dyspnea you bring in first because it is only the pleural cavity is involved first.
Yeah.
Through the
No, not even that. Dyspnea is not the first one. Which is the first one you should bring in?
Bone pain.
Yeah, it should be in that order only. That shows, see, not just having knowledge. Application of knowledge is also equally important. Okay, you should not let the examiner ask you these questions. It should be like clear cut in your presentation only. Okay.
Yes.
First of all, you are not proved so far. Why you have taken the history of metastasis now? Have you proven that it's a carcinoma?
No, sir, I haven't proven.
Then why you are asking about a metastasis now?
You should have written no history of any other symptoms of bone pain or dyspnea or abdominal pain or any headache. That will be sufficient. That is enough. Not the suggestive of metastasis means you are going with the prefixed idea that it is malignant tumor. No history of complaint in the right breast. Okay.
Why you ask about the right breast?
So I asked if there is any if you take lobular carcinoma, it is bilateral first. So I just want to confirm if there is any lump in the right breast, or if there is any other discharge or something from the right.
Not just lobular, many are familial cancer like malignancy also. It could be bilateral. Okay. So come to family history. I'll ask you. Go to next slide. Past history.
No, nothing is that. Why did she undergo hysterectomy any new or postmenopause?
Yes, she attained menopause at 50 years of age. Sir. After 10 years, she got postmenopausal bleeding. And when she got evaluated, she said that it's endometrial thickness and hysterectomy was done. When biopsy report came out as no, it is a benign lesion like that. She said, sir, I didn't see any reports.
Okay. Go to the next slide. Mixed diet of this one was smoker, alcoholic, patient taking low fat diet. All these are more prone for malignancy.
Yes.
Okay. Next slide. Yes. Is there any risk factors in your menstrual history?
Sir, no, sir. Actually, early men. I know, sir.
When do you call it as early menarche?
So early menarche when the girl is attaining menstruation before 12 years of age.
Now it has become less. There some books give it 10 years.
What's the difference between early menarche and precocious puberty?
Yes. What is it?
Early menarche is less than 12 years. Precocious puberty, I think with secondary sexual characteristics, there is no menstruation.
So she didn't have any early menarche or late menopause. She's
Why you want to ask all these things? Why you want
early menarche and late menopause is a risk factor for breast carcinoma, sir. Because of high estrogen exposure because she used to ovulate more, and in every menstrual cycle there is high estrogen exposure, and she's prone to get malignancy.
So the brunt of the attack of the estrogens is more in a nulliparous, late marriage, late childbirth, early menarche, and late menopause. So otherwise, she's not at any risk now. She doesn't have any risk factors. Okay. These are all modifiable risk factors. Any non-modifiable risk factors, you know?
So non-modifiable is first of all being a female, then increasing age.
Good. Then
Family
history.
Family history.
Genetic predisposition also.
Yes, sir.
Okay. Go to the next slide.
Why history of abortion?
So in a full-term pregnancy, there is a terminal differentiation of the duct. It is a protective factor for breast carcinoma, sir. But abortion, it is not a protective factor, sir.
Okay, one is that. Second,
history of repeated abortion, if the patient gives you, do you think it is a risk factor or not?
Yes.
The participants are silent. I don't know.
Abortion, abortion happens 4 months, 5 months of pregnancy.
Yes,
so
sir.
full term is 9 months. So what's the difference between abortion and a full term pregnancy? Again, more cycles.
More cycles and more estrogen exposure.
Abortion, then again she exposed for more cycles, correct?
Yes,
And the full term this thing. Next.
Yes. What is this BRCA?
So BRCA is breast carcinoma gene. So it has two things:
Breast
BRCA1 and
carcinoma.
BRCA.
Breast carcinoma. A, what is A? Breast carcinoma gene. Yes, BRCA, aortic breast carcinoma gene.
Yes,
of this, which one you want? 1 or 2?
So breast carcinoma one is a 1, sir. It has
is it associated only with breast carcinoma or any other carcinoma?
It is associated with ovarian cancer, colorectal cancer, pancreatic cancer.
Very
and
good.
Yes.
Okay, what other familial conditions you were wanted to know?
Leigh-Fermini syndrome, in which P53 mutation is seen, sir. Lynch syndrome, in which there is HNPCC, hereditary non-polyposis colonic carcinoma, and in Cowden syndrome, there can be PTEN mutation.
What do you look for, or what do you ask the history of in? How do you ask Cowden's history? Cowden syndrome. What is the pathognomonic or classical feature of Cowden's? Looking at the patient only, you can make out. Cowden syndrome, you need not have to ask any history or anything. It's some classical features on face.
Have you read? You can read.
Multiple facial trichiloma means from the hair follicles there will be small. That's a tumor kind. Okay. Along with that, hematomatous polyposis, this intestinal polyposis. Okay. Then there are so many other things, lipoma, thyroid cancers can be there. There are so many other things associated with Cowden's. And ataxia telangiectasia, that's again another familial condition you should be knowing. Okay. Very good. Next.
Yeah. Go to the next. Go to the local examination.
Local examination. Can I start, sir?
Yeah, carry on, please.
Okay.
General
physical examination. Patient was examined in a well-lit room after taking proper consent with adequate exposure. Patient is conscious, cooperative, and well-oriented to time, place, and person. She is well-built and overnourished. Because her weight is 79 kgs and height is 156.5 centimeters.
Patient should be examined in the presence of a female attendant. You may be a female, but you should examine it in the presence of a female attendant. That is almost. You have a staff nurse? No. You have the female attendant with them. That will be because litigation problem. We are facing a lot of things only when you come to the practice, you know. You examine in the presence of a female attendant. Don't say that I am a female, I had a staff nurse. Okay, that will be. We are refining you. You're good in presenting. Your presenting is good. You're answering well. So nothing in your
mistakes. Okay, we are not pinpointing your mistakes, but how can you improve on your presentation?
Yes, sir.
In your this present slide, anything related to the diagnosis or risk factors or anything significant?
So she is class 2 obese, sir. Obesity is again, there is a peripheral conversion of fat to estrogen, and again there will be high estrogen exposure leading to, again it's a risk factor for this person.
Yeah, postmenopausal obesity is one of the risk factors. Okay, then
What is this Karnofsky performance score is for?
The Karnofsky performance score is it's a score like in which in 100 means the patient is healthy.
No, that's okay. I understood. What is that for?
To assess the mental status of the person.
Not just mental.
How,
in malignancy, you bring in ECOG score.
okay.
This is mainly for the chemotherapy, how to know the fitness, mainly for what this leukemia, other things for fitness, whether the patient is fit to receive the chemotherapy or other adjuvant therapies or not. For that, we check this performance scores. Okay. Yeah, okay, you can take ECOG score or Karnofsky scores in any malignancies, but why that you should know.
Okay.
Next.
Vital signs.
Yeah,
Next.
Nothing. Don't bring this radial, no radio.
Yeah.
Is it important? Yeah, go to that slide, please. Next time when you present, because where do you get radial, and radio?
I tell this in every
question. See, you're prompting the examiners to ask you question and make you blush like this.
Leena,
you ask where do you get radiofemoral?
Yes.
Tell me.
Only one condition.
Coarctation of aorta.
Now, what is coarctation of aorta? See, again, the question will go in that you are pulling the examiner to the grave side.
Where you get radial delay?
Radial.
So, vasculitis like Takai's or arthritis.
No. Anyone in the Aditya, please answer. Anyone in the chat box can answer. Where you get see in the books, everything will be given for the completion's sake. It doesn't mean that you have to include everything in every case. Which are applicable here only, then you have to include. Is it okay?
You have any vascular cases, you can write, ma. Otherwise, is it pulse normal?
Preductal, very good. He answered perfectly. It's in the reverse coarctation, also called preductal, before the subclavian. Okay, before the subclavian, that branching is there on the left side. Before that, if there is a coarctation, see, on the right side, it's given like first, and after some delay, that gives to the left radial. Understood? So, radial delay. So, postductal, after the subclavian, if there is a coarctation, then both the arms get at the same time, but to the femoral, there will be a lag will be there when the pulse goes. Understood, no? Simple.
Okay.
Only one condition you get. So you need not have to mention it in every hernia case or all the cases. Okay. Good.
No. Come to your local examination. We have to go with supine sitting, palpated and semi-recommend in sitting position. Right. Go to the next slide.
Why semi-recommend? Why you prefer that position particularly?
So in semi-recommend position, the lump will be, we can palpate the lump easily against the wall.
Why not sitting? What's the problem with sitting?
In sitting position, if the breast is pendulous, we will not be able to appreciate. And when she's lying flat, it will fall onto the couch. So again,
laterally. Okay, so semi-recommended by, because inframammary fold, it may be visible clearly. Okay, it will not fall laterally. So that's why semi-recombinant is 45 degrees preferred. Okay. Next.
Where do you put the supine position? Can you palpate? Huge breast, huge pendulous, huge breast, massive breast. You can, if there's you can ask the patient to lie down, keep a pillow under the right breast, you can palpate. Otherwise, the typical classical is semi-recommend is good. Now, in each one, you have got certain things. You have to inspect in the sittings by the arms by the side, arms raised above and bending forward. Now tell me what will you look for in sitting by the arms by the side?
So when it is in arms by the side, I look at the symmetry of the breasts, whether both the breasts are symmetrical, and I look for any obvious skin changes if it is present.
First you have to look for whether both the breasts are present. Okay, or it is there accessory breasts are there. Okay, suppose one side breast has been removed. You didn't say, but inspection you should say both the breasts are present. Now you go into the symmetry. Then you said size, shape, fullness in the upper outer quadrant. You can look for, instead of writing no engorged veins, scar, sinus, no skin changes will be a simple word.
Okay.
When there is no engorged veins, scars, sinuses, Where do you get sinuses in the breast, ma? Is it
Sir,
common?
not
Is it common?
sir.
Not that
In
common.
case of any
So you can,
retromemory,
you're making us to ask more questions. So you can say skin of the breast is normal. That will suffice everything.
Abnormalities
So
can be hundreds. You can't mention everything. But if it's normal, only one possibility is. If any abnormalities are there, then mention. See, this is there. Understood?
yes, sir.
You can't, need not mention all the unnecessary abnormal things.
Okay.
Is it clear?
Dimpling, puckering, noted. That also you can learn skin is normal. Go to the next slide. Now, one tricky question. You have a pure orange, body orange, and a dimpling, puckering or
Yes, sir.
tethering. Which do you think is more malignant? Which sign is more malignant? It's a tricky question. You can answer.
Pure orange is
Pure,
pathognomonic.
that's one. Pure orange, body orange can occur even in breast abscess or any acute inflammatory condition. Body orange can occur. Whereas dimpling, puckering, or tethering, all are same only. Tethering is a palpatory finding. Puckering is nothing but multiple ligaments. Ligaments. Dimpling is a small ligament. So that is more in favor. That occurs only in malignancy. Whereas body orange can occur in other conditions. Of course, it can occur in malignancy. Then they were, when you ask this question in the exam, be sure to answer that dimpling and puckering is a more sign, sir. Body orange can occur even in other breast abscess. Nipple area complex at a higher level. You can say normal, ma. You can say nipple area complex.
Okay.
Lying at
upwards and
in left sided breast, it is at a higher level compared to right side.
Okay, fine.
Okay.
Next.
Suppose you see a huge breast.
Yes.
What are the causes for a huge breast? Huge breast. So the affected side is right side and you have a huge breast. What are the causes for he is telling 4? You can say at least 2.
It can be more. I don't know. You tell.
No, you can say. One is a galactosele.
Is breast hypertrophy.
Very good.
Congenital hypertrophy of the breast, that is a congenital condition which occurs bilateral. That is bilateral.
Very good.
Unilateral is one what? One is one mainly benign condition which produces huge.
There are minimum 5, 6 are there. Minimum. One is bilateral, this hypertrophy. Okay, great. Then.
No, I'll tell you. Then is phylloids tumor.
Phylloids tumor.
Then filaris breast is another one. Sometimes medullary carcinoma of the breast, a rare carcinoma which can produce a huge tumor. Okay, galactosele, all can produce
Giant
a huge
fibroadenoma.
Giant fibroadenoma. Yeah, I forgot that. Giant fibroadenoma.
Sarcoma. And colloid tumors. Okay,
colloidal carcinoma. Okay, go ahead. No, you inspection raised, arms raised above.
Is in arms raised above. The lump got prominence, sir. I could see that. And there is no other skin findings. Nipple retraction is present.
The 3 things which you look for arms raised above, one is a non-visible lump becomes visible, or a visible lump becomes more visible. One. Okay, you understand?
Yes, sir.
Non-visible lump becomes visible, or a visible lump becomes more visible.
More visible.
Number 2 is you can look for puncturing, tethering more. And most important is the inframammary region. This is for arms raised above. And axillary fullness, you can see. Now you said bending forward. Why?
So bending forward, on the side, I can go to the side of the patient. I can look at whether the chest wall involvement we can first of all see. So whether it is falling freely, and also the level of the nipple.
Bending forward, you look for only one thing. One is
chest wall involvement.
What is chest wall involvement? What is chest wall composed of?
So chest wall composed of ribs, intercostal muscles, and serratus anterior muscle.
Serratus anterior, you say later. Intercostal muscle, ribs. Serratus anterior usually occurs when there is a lump is the outer quadrant or inner quadrant. Outer lower quadrant. Okay.
Yes, sir.
Which quadrant is more common?
Upper outer quadrant.
Why?
Because of more breast tissue present there.
Okay. Go to the next slide. Palpation. Yes, no local. Upper outer quadrant. Yes. Well-defined margin. Keep presenting.
Yes, sir. Palpation, there is no local rise of temperature or tenderness. A lump of size 4 into 3 centimeter in greatest dimension is present in the upper outer quadrant of left breast. It has well-defined margins, surface is smooth. It is hard in consistency, fixed to breast tissue, but not to chest wall or underlying muscles or to the skin. Nipple areolar complex appears to be normal. Regional lymph nodes, a single lymph node measuring 2 into 1 centimeter in pectoral group is noted, which is non-tender, mobile, and not fixed to surrounding tissue. There is no supraclavicular lymphadenopathy. Examination of right-sided breast and axilla is found to be normal. Systemic examination.
The systems are clinically normal.
Yes, sir.
So of this one, which system will you examine first? Go to the one. Is cardiovascular system first?
No. Firstly, I think respiratory.
One is respiratory or the skeletal
Per
system. Skeletal system per abdominal examination. Okay, now skeletal respiratory system, what will you look for, Amy?
So in case of malignant pleural effusion, there can be dyspnea. There can be tachypnea.
So the patient will not cooperate like this one. So look for any dyspnea or signs of pleural effusion one. Right.
Yes,
cough with hemoptysis very rarely occurs when there is spread through
lung
the blood. Lung parenchyma is involved. Usually the pleural cavity is involved first. That is why you get more of pleural effusion. Lung parenchyma very late. There only you will get destruction of the lung parenchyma, cough with hemoptysis. So respiratory system is over. Per abdominal, yes, said. Per abdominal examination, what all will you look for?
So per abdominal examination, there can be ascites due to the
you come in an order. You can come in liver, liver, then umbilical nodes, ascites. These are the three main things you can look for. Okay. Huh? Right.
Yes.
Will you get ovarian tumor ovarian involvement in this lady?
So there is something called as breast ovarian cancer syndrome. There is a similar risk factors for breast ovarian cancer. So, yeah.
No, will you get Krukenberg's tumor?
It's via peritoneal.
No, in this lady, in this lady.
Is asking in this particular lady. I understand the question. Okay, separately ovarian cancer can occur. I agreed. Okay, but in this particular lady, because she's a known case of carcinoma breast, can she get a ovarian metastasis also? Sir is asking.
No, it usually occurs in a
Krukenberg's tumor. Sir is asking about
ruptured ovarian follicles. When the follicles are ripened only, you get deposits. It's a retrograde lymphatic permeation. That was the recent theory. Previously, they said from the peritoneal, from the above downwards, through the nodes you can get it. Okay. Now they are telling Krukenberg's tumor can occur. There's a lot of questions will come if you keep on asking. Is it solid tumor, bilateral, solid or something? What is Krukenberg's tumor? You can read. So you have to look for the examination of the. You are not mentioned perrectal, pervaginal, not done. Okay, this should be done. Okay. Which will you do first, PV or PR?
PR.
Think. Which is sterile? To do a PR and do a PV? PV first, then PR. Okay. So no focal neurological deficit. Now, where is the skeletal system examination? No? You're not put.
No, sir.
Where do you look for the skeletal system?
That should be the first one, okay? In this breast, any system.
Which system?
Bone,
which bone?
Vertebra, sir, along the paraspinal tenderness. It is present.
Paraspinal tenderness, the lumbar region. Through the?
Yes. Bone metastasis.
No, how does it go to the lumbar? This is a common question.
Through the Batson's, through the lymphatic
plexus of Batson. Okay. So you have to look for the long bones also. And also the sternum, if at all the patient complains of pain. Otherwise, you can go to the next slide. So with these findings, what do you say it is? What previously you said postmenopausal 64-year-old lump of 7 months. Now, in your palpable clinical examination findings, which is the one to say it is malignancy? Apart from one, what?
Firstly, the location, sir, it is an upper outer quadrant. This is the classic location for the carcinoma, and it is hard and consistency. And also, the nipple areolar complex is deviated towards upward out and outward. And also, there is a palpable lymph node present in that region, sir. So probably, I think it is a
You said we have left one important point which you have written. Fixed to the breast tissue. Fixed to the breast tissue. So I probably think it is a carcinoma.
Yes.
Now, staging, how do you stage this one? Is it you bring, go to have you written staging?
Next
Yes,
slide.
sir.
Left staging. C, what is C?
It's a clinical staging, sir.
T2, N1, M0.
Yes, sir.
So it comes under stage
Stage
2B.
2B.
So it is early.
It is early, sir.
Why
1
not
and
local?
2.
Why not locally advanced? We'll rule out the other ones. It is not metastatic. Clinically, it is not metastatic carcinoma. It is not locally advanced. Locally advanced means, which is, what do you mean by locally advanced breast cancer?
Multicentric, multifocal. Stage 3 breast cancer, sir.
Stage 3. So what out you have this 4A, 4B, and 4C, isn't it? What are they?
So 4A is involvement of chest wall. 4B is skin changes like satellite nodules, period orange appearance, and ulceration. 4C is chest wall involvement plus skin involvement. 4D is inflammatory breast carcinoma.
Right. Here N1 you said. Okay. So stage 2. So it is coming under early breast carcinoma.
Yes, sir.
You have heard of LABC. What is LABC?
Locally advanced breast cancer.
What is LOBC? Have you heard? It is large operable breast cancer. Even it is a big, more than 5 centimeters coming, it is called LOBC, large operable breast cancer. So don't confuse yourself. Now, yearly breast carcinoma. You have a case with you, 64-year-old. How are you going to investigate? Forget the, you're running short. Forget the local
No,
investigation.
sir. Time is not a constraint, sir. Please, sir.
Okay. What are the local you straight away go in for mammography?
First, I'd like to confirm my diagnosis, sir.
Why you want to do?
So that, firstly, I would like to do
You'd say
mammography.
hard fixed lump, large lump. Why you want to do mammography? The question will be asked usually. This breast. Why can't you directly put in a needle?
Directly core needle, sir. So because mammography, if we do after needle investigation, it can change the tumor.
No, ma'am, they will ask the answer which they expect from you, yes, because it can be a multicentric or multifocal. So I would like to do a mammography to look for any other lump in the other quadrants of the breast. That is why you do. Sonomammography is done in younger individuals. In older individuals, you do a mammography. So mammography is a low voltage, high ampere X-ray. Yes, what are the views you know?
So there are 2 views, sir, craniocaudal view and mediolateral oblique view.
Mediolateral oblique. Have you heard of one more thing called Cleopatra view? Semi-reclining position. You can read about it, no problem. You have answered well. These are all extra points we are telling you because you are answering well. So you do a mammography.
Only for screening. It's only for screening, those 2 views. For diagnosis, there are other views also, compressed views.
Compressed views are there. So what are the mammographic findings? Okay, you have done the mammography. What are the mammographic findings to say?
Radiologist will give a BIRAT scoring, sir. Following
I don't know
breast image.
No. What are the features suggestive of malignancy on mammography?
Okay.
Simple. See, listen to the question carefully. What are the mammographic features suggestive of malignancy?
There will be irregular spiculated margin and there can be microcalcification. First of all, there can be architectural distortion.
That should be the first one. Architectural distortion.
Solid mass, architectural distortion. Pleomorphic clustered microcalcification.
Spiculated margin. Then if there is any lymph node involvement, that will also be.
Then cells also sometimes you can say, if they pick up very good, they'll get taller than wider cells. Okay, these are some of the things in mammography. So mammography.
How small is microcalcification?
Less than 1. 0.5.
Very good. 0.5.
0.5. Good.
Excellent. So calcification, you told microcalcification you see in Malignancy. What other types of
Malignancy.
calcification see you in breast?
Popcorn calcification is seen in case of fibroadenoma. Lead pipe calcification is seen in case of traumatic fat necrosis. And
Fibroadenosis, what can you see? Powdery calcification. Okay, powdery calcification. And in benign other disease you get?
this segmental.
And what you told about this? Lead pipe, or I know it's
Lead
curvilinear
pipe.
fat necrosis. Lead pipe, is it?
Is in traumatic fat necrosis.
So these are all your MCQ questions. Be prepared, all those things. Okay, good.
Core needle biopsy.
Yes, sir.
Which is better, FNAC or core needle biopsy?
Core needle biopsy, sir, because here we are getting the tissue. We can see the invasion. The invasiveness also we can see. Also, the hormonal status can be assessed. So, good sensitivity.
You can look for two more things. You can look for two more things. One is because the post-operatively, the radiotherapy can be depending on the differentiation of the tumor. Poorly differentiated, has got a poor prognosis. Then lymphovascular invasion can be seen in a core biopsy. What is the size of the core biopsy you take? You know the needle size?
18.
16. Okay. No,
For
straight
FNAC, how
away.
much?
FNAC?
23.
23.
24. Okay, good.
23 or no. Okay. So receptor assay. What are the receptors you look for?
So, ER, PR, and then HER2 new receptor, sir. ER and PR are nuclear receptor, HER2 new is membrane.
Which has got a good prognosis? If they are positive or negative?
If it is positive, it's a good prognosis, sir. We can provide the patient hormonal therapy.
When do you say it is positive?
So, in the immunohistochemistry markers, when they put, if it stains, it becomes brown in color.
No. There's an index for it. Do you know for the
Okay,
index?
67 index.
No. For
That's separate.
ER positive, that's called femtomoles.
How
Femtomoles.
many?
More than 10. Okay.
Okay.
So
tell HER2 new positive, how much it should be on IH, this thing, immunohistochemistry. It's graded as 1+, 2+, 3+, 4+, like that. So to tell
Yes,
it's
sir. It is 3+, sir. If it is
very good.
2+, it is indeterminate. Then we have to carry out fluorescence.
Positive. 2+, it is 2+.
It is indeterminate. We need to carry out fish, sir, fluorescent in situ hybridization. So that if it is coming out as positive, then it is.
Excellent.
But 0 and 1+.
What is actually HER2 new? What is HER2?
Herceptin.
Herceptin is another name. No, Herceptin is another effort. Trastuzumab.
Nice.
What is HER? See, that's what Srinivasan sir was telling. You will read only short forms and what is BMR?
The basal metabolic rate.
What is BMI?
Basal metabolic. Body mass index. Body mass index.
This is what happens. Okay, short form.
Human
epidermal growth receptor. Okay. HER, human epidermal growth receptors 2. Okay.
Human epidermal growth receptor. Right. You wanted to go for a CECT chest and abdomen. For early breast carcinoma, I don't think they advise, but since you're working in a big hospital, which has got everything you can do. Otherwise, where we studied, depending on the institution. For early breast carcinoma, you can do a chest X-ray, if needed, an ultrasonogram of the abdomen, the basic investigation you say. For locally advanced, of course, you can do a CECT chest. You have written, probably you would have been taught like that. Bone scan is not necessary, I think so. Because you say absolutely no bony pain, why unnecessarily touch the patient? Whole body PET CT, I am not for it. The patient is, clinically, we have got a differentiated carcinoma with the early breast carcinoma. I don't think a whole body PET CT scan is not. What is the FDG?
When you answer, no?
Fluorescent
should be related to this particular index case, not in general carcinoma breast. In this particular case, what are the investigation you want to get done? Not the all general investigation for CA breast you should be mentioning. Is it clear? What is FDG?
Fluorescent deoxyglucose.
Okay, because once you take an X-ray chest or something, you find something, then you can go in for the next mode of investigation. That's what, as an undergraduate for early breast carcinoma, I suggest. If it's an LABC, I think you can go in for a CCT, chest, abdomen. Bone scan, I'm not for a bone scan. Okay.
What are the indications for MRI?
So if it is a young patient who wants a screening, and if it is a dense breast, and in case of implants in a breast, or in case of a scar or recurrence, if you want to find scar recurrence, and
Pregnancy?
and if it is pregnancy, ultrasound can be. So yes, dense breast MRI can be.
That is good. That's good. For your level, it's good. There is one more criteria. If you want, you can read something called Chaudhary-Miller's criteria to differentiate between the primary and secondary on the opposite breast. Okay. Don't confuse yourself. Now, with your thing, you're answering well. Go to the next slide.
The last one.
Now, what is the treatment you want to give? You're confirmed. You're done all the investigation. Everything is normal. Chest, X-ray, everything, abdomen, everything is normal. You
Yes,
got
sir.
invasive ductal carcinoma, lymph node positive.
Yes, sir.
What is the treatment you want to give? You want to give surgical, or you want to give something else and do surgery?
So since this
In
is
your case,
in my case, I would take the patient directly for a surgery, sir.
yeah, you're taken up for surgery. Now, what
Yes,
surgery would you like to do?
So modified radical mastectomy can be done along with axillary lymph node clearance, sir.
Right. If it is a young lady with the
Why not
same
BCS?
lump, yeah, that's
So
what I'm
breast
asking.
conservation surgery, yes, sir. For this patient, actually, for breast conservation surgery also can be done, sir. But post-op, we need to give radiotherapy and all that. I can offer the patient both. Since her age is 64, I think, if she is okay with modified radical mastectomy, we'll take her directly for that.
Main
So that
thing is compliance for the
Mhm.
radiotherapy and all that would be difficult in elderly patients and all. And the
Yes,
breast size and that ratio also, you should see tumors ratio also. Okay. So
Tumor
all
breast.
like in the age also, considering everything, okay, you can offer a MRM, modified radical mastectomy. So what are the types? Which particular modification you want to go with? There are so many types of MRMs, right?
Yes, sir. Patty's Scanlon Austin clause. In Patty's, the pectoralis minor is divided.
What do
in,
they do? What
scan.
do they do in your hospital?
So for
We
this
know.
patient, modified radical mastectomy was done, sir.
No, what type of radical? What type? Is it Achin class or Scanlon or Patty?
Austin clause, sir.
Achin class.
They just retract the pectoralis minor and they clear the
lymph nodes. Up to which level?
The lymph node clearance, superiorly it should be up to axillary vein, inferiorly up to
Level 1 and 2 nodes.
Level 1 and 2.
Level 3 nodes
prevent
means
lymphedema mainly. Okay.
okay.
Yes, sir.
Clear out everything, all the lymph node. There will be no post-op drainage is difficult, so it can lead to
That can be lymphedema.
lymphedema, which is very cumbersome. If the chronic lymphedema can further
Still
lead on.
treats
Yes.
lymphangiosarcoma.
So what are the structures you remove in mastectomy, modified radical mastectomy?
Modified radical mastectomy, the breast tissue, nipple areola complex, pectoralis major is not removed. Pectoral fascia, yes, sir.
Okay, carry on, good.
Yes, sir.
Axillary
And the structures,
clearance.
axillary clearance.
You said boundaries. You started off. That's what I'm asking. Boundaries of axillary dissection.
Superiorly axillary vein, sir. Inferiorly the bifurcation of the thoracodorsal pedicle, and medially Halstead's ligament, and laterally the.
You won't go up to the Halstead's ligament. Yeah, stop with the chest wall. So you, from inferior, there will be an angular vein.
Yes, sir.
It's not the thorax, it's an angular vein. What are the structures you preserve?
So, pectoralis major, then medial pectoral now.
In the axilla.
Axillary vein. Thoracodorsal pedicle.
ABC, and you said axillary vein. What is B? B for Bell's nerve. Bell's nerve, cephalic vein.
Yes, sir.
Then the thoracodorsal pedicle. Okay, you are done an axillary lymph node clearance. You are finished with your surgery.
Yes,
right. How will you follow up this patient?
It's one correction there. It's not clearance, actually. It should be dissection. Okay. Axillary lymph node dissection. Clearance means all entire thing you are taking out. That will be the axillary lymph node clearance. Okay. Dissection means only the involved ones you will dissect out.
Okay.
Okay. lymph maxillary clearance. Now, how will you follow up the patient?
The patient, initially, the most common complication is serum malformation, drain.
No, everything is fine.
Okay.
Patient is discharged. What are the next things you want to do? You send the patient home, ask them to come after some time.
So mammography can be done 6 months.
No, why?
before.
No. Is the treatment over? Is the treatment over? I'm asking.
Yes, sir, it's over. Sir.
Over.
Okay. No, you have sent the specimen for histopathology. Once the report.
Sir, once the report comes, we need to tell.
Up, no?
Yes, sir. Yes, sir.
So
if it is poorly differentiated, then we need to put the patient on. If the margin is coming out as positive, we need to take the patient for radiotherapy or.
Node positivity.
Then access to the axillary region also radiotherapy.
What are the indications for radiotherapy, post-op radiotherapy?
Indications for radiotherapy post-operative margin positivity, sir, and if there is any lymph node involvement and.
Lymph node involvement, lymphovascular invasion, high-grade tumors,
and BCS. BCS.
All this.
After breast conservation surgery. Okay.
Will you put the patient on chemotherapy?
So for this patient, it's not needed, I think. So. Node positive. So. Hormonal therapy can be if the hormonal status is.
Chemotherapy is advised because they said it is breast tumor. There's a lot of things we want to discuss. We cannot discuss a lot of things.
Systemic disease.
It's a tumor doubling time is there, and it's a systemic disease. There are two concepts: Halstead's concept, Fisher's concept. When the tumor starts developing itself, there is micrometastasis. So you have done a local clearance of the tumor. Now you have to deal with the systemic tumor. So definitely you have to go in for an adjuvant chemotherapy.
What regimen you prefer?
What regimen you prefer?
ACT regimen, adriamycin, cyclophosphamide, and taxanes paclitaxel can be offered to the patients.
Okay. Well, are there any? You usually put. What is the dangerous complication of adriamycin? Before giving adriamycin, what will you look for?
Dilated cardiomyopathy, ECG.
So you should look for the cardiac status.
Yes.
So you give how many cycles you give?
6 cycles.
Yeah, 6 is okay. 6 is okay. Different. You do give 6 cycles of chemotherapy. What do you mean by 1 cycle? So you give it today, tomorrow another cycle, day after tomorrow another cycle. Do you know that one?
No, sir. I don't know.
So if you give one,
central vein.
No, you can give it, ma. You can give it not in the central vein. There is something called pre-hydration. Then you start the drug. Then you give a post-hydration. Observe the patient for 1 day. Then you discharge it and you give it on this the same week, or you ask them to come after some days. So 1 cycle means it contains 4 weeks gap, because all chemotherapeutic drugs are bone marrow depression.
Bone marrow depression.
So you give it today means you ask the patient to come after 4 weeks. After 4 weeks, when the patient comes, again you have to repeat all these investigations. And if everything is normal, you start the second cycle. So that is called 1 cycle. It's not 1 day, second day, and finish it within 6 days. No. You have to take at least 6 into 4, 24 weeks to complete the cycle. So adjuvant radiotherapy, as we had some indications, you can give radiotherapy 200 centigrade per week. You can give to continue. Okay. 200 centigrade per week. That is at least for 5 days. You can give 40 centigrade per day. You can give radiotherapy. What are the complications of radiotherapy given to the axilla? You can give it to the chest wall, breast.
Yes, sir. Again, after lymph node.
Yeah, you are likely going for post-radiotherapeutic lymphedema. You get too much of radiation, we'll go in for lymphedema. What are the complications of that lymphedema later on?
So the lymphedema can later on turn into lymphangiosarcoma, sir, which is called as Stewart-Pearce syndrome, in which there will be, it may even need the complete amputation of the limb.
What
So
is the
usually
treatment
as
for
a
lymphedema? What's the
Don't
treatment?
answer too much. Don't answer. Yeah. What means is syndrome, Stewart-Pearce syndrome? Don't
What's the-
say it's not your limb, it is somebody's limb. So we have to treat the lymphedema. That we can treat that well. If
the
they
treatment?
ask you, you tell. Okay. Otherwise, don't tell. What are the complications this can occur? Too much of lymph node dissection, too much of lymph node removal. That's what not. You cannot simply keep on clearing everything. You have to be meticulous. Too much of lymph node dissection, too much of a radiation can produce lymphedema. That to prevent lymphedema only, we are doing meticulously. Okay.
Yes, sir.
PR positive. What
Yeah.
extra adjuvant therapy you want to give?
So, hormonal therapy in a postmenopausal women, we can give aromatase inhibitors, letrozole, anastrozole, letrozole, all that. Premenopausal women, we can give selective estrogen receptor modulator. Like
What is the problem with again this taxanes? Sorry, not this. What is this? Aromatase inhibitor. Sorry. What is the main?
Sir, osteoporosis.
Yeah, one is
It can cause
osteoporosis. Second is again cardiotoxic. If you combine this taxanes and this thing, what is it? Adriamycin and all, then it will be again totally cardiotoxic. And, okay.
And cost factor also is too much.
High. Okay.
So
What
you
is
can-
HER2 positive?
the HER2 new positive, we can offer them Herceptin, trastuzumab.
Do you know about this intrinsic subtypes depending on the molecular? What is it?
Yes, sir. It's a molecular classification of breast carcinoma.
You just name.
We have got luminal A, luminal B, base.
HER2 new rich, luminal B, B1, B2 are there. Okay, read about all those things.
Which has got good prognosis.
Yes.
So luminal A, it is triple positive. Luminal B, it is triple positive. Sir.
Triple negative, what is the main line of treatment?
So if it is triple negative, then we have to lay on chemotherapy, sir, and surgery if possible, sir.
Surgery if possible.
Other modalities of treatment, sir, because triple negative, we can't offer them hormone.
So having come to this, if suppose this case has been an LABC, a few minutes on LABC, locally advanced breast carcinoma. Suppose the patient has got a huge tumor with a skin infiltration or skin changes. What is your plan of management? Here you straight away offered surgery. In LABC, what is your first line of management and how will you proceed?
So neoadjuvant chemotherapy firstly given to downstage the tumor, and then we have to reassess the tumor and stage accordingly. Then plan the next management, be it surgery.
How many cycles you give? Neoadjuvant.
Half.
You can follow your, because everyone has got, even every institution has got. Now the oncologists prefer to give full and then operate. But you can say, I will give 3 cycles prior, see the response, then I will go in and do a. Suppose you give 3 cycles, the tumor completely disappears. Will you bring it down to early breast carcinoma or will you keep the staging at LABC?
After downstaging the tumor, we can, again, I'll put it as early stage, sir, because we need to, when we reassess, we can change the staging.
So you think you can go into breast cancer. No, that is going too much. You can say the first one is your first diagnosis. So based on the tumor response, I will go further and do an upfront surgery. So what surgery you do? In this patient, we are taxing you too much. So you'll do again the modified radical mastectomy. Okay. What is the advantage of giving neoadjuvant chemotherapy prior to the surgery?
To make it an operable tumor, so if it is so huge, we can't operate
it. It makes operable. You can downstage one.
Downstage.
Number 3 is you can know the response of the chemotherapeutic drugs to the tumor. If it is not respond, you can change the cycle. So you can change the drugs. That is it. Then you can do an LABC, then do a mastectomy, neoadjuvant, followed by surgery, followed by post-adjuvant chemo, then radiotherapy based on other things. Okay.
Leena, lady wants to know about the how much risk she's carrying to getting breast cancer, or what is the chance of recurrence, what is the prognosis and all. So do you have any mean to know this exactly?
So you can know the mutations, the type of mutation she has.
So the question is, what is the ways of genetic mapping or genetic expression profiling?
Okay, there are many things. Mammogram 70,
Not
oncoprint,
mammogram.
mammoprint 70, mammoprint 70, oncode type DX. Like
Very
that,
good.
there are many.
PAM 50. Okay.
There are a lot of things. Breast mapping has come, stereotactic
These are the questions
biopsy,
for your
lot of things. But
MCQs.
I think for undergraduate, I think you have done extremely well, ma. For undergraduate, you have done extremely well. So a case comes means this is how you answer. Early breast carcinoma because of this one. I will go in for a surgery. If it is younger group, and there are some contraindication for BCS, you should read. So when their contraindications are not there, I will do BCS. So that is breast conservative surgery consists of three things. One is lumpectomy, three components of BCS: lumpectomy, axillary sampling, post-operative radiotherapy. These are the three components of BCS. Okay, but you should have the indications for BCS, but not in this lady. This lady, I will do master.
Quart,
Okay.
quart, you know, quart. QUART. Quadrantectomy, axillary dissection, and radiotherapy. Quart. QUART. What's called? Okay. You should read about this. If you're doing BCS, you should do sentinel lymph node biopsy that you should do reading about. And sir, also then what are the questions? Complications, all you should read about. Okay, what are the possible complications of what happens if you injure intercostal brachial nerve?
So intercostal brachial nerve, if it is injured, then in the medial aspect of the chest and in the medial aspect of the axilla, there will be sensory.
That's the one nerve you can contribute, injure, okay, or sacrifice during your dissection. Okay, other nerves should be preserved, like especially this median pectoral and lateral pectoral nerves. Okay, even if you preserved pectoralis major muscle, and if you injured the nerve, then use. Okay, so you've done really well, sir.
Yes, sir. Extremely good. Keep presenting well.
Excellent, excellent. Okay, so
I told my students also to present, sir.
Please, sir. Any doubts you have, you can ask the professor directly. Or Leena, you have any doubts or any others? If you have got any doubt, you can ask, sir.
Even I told my students to present. They said they'll prepare and
the last batch, those who just finished, they're too good. They're very active and they have presented so many cases. Please present batches also from because Coimbatore Medical College is one of the very eminent institution. Students are also very good there. So we want some presentations from.
I will ask them. I will ask them to. We'll ask them to do. Any doubts, anybody, you can ask or we can wind up. Thank you for the opportunity, Kishan.
Thank you, sir. Thank you so much.
Well done, Leena. Keep it up.
Yes, sir. Thank you.
Thank you.
All participants. Thank you, Kishan. Goodbye. Good night.
Thank you so much.